Beta blockers are recommended by guidelines in treatment after myocardial infarction also with an ejection fraction above 40. But the evidence for this is outdated. It's quite old. It was before we had routine revascularization, before we had statins, before we had the effective treatment we have now. So therefore it's been questioned whether we should still be giving a beta blocker after myocardial infarction. And now several trials are addressing this. We have looked at it, we have started our trials in Denmark and Norway, 2 independent nationwide trials, investigator initiated. One was DANBLOCK and the other one was BETAMI. And altogether we have included 5,574 patients and we have followed them for a median follow-up of 3.5 years. We have collaborated between the 2 trials. They were performed independently, but we decided several years ago to collaborate because individually we didn't have sufficient power to answer the question that we had. So we have now concluded the trial. The primary endpoint is all-cause mortality, recurrent myocardial infarction and heart failure, in addition to arrhythmias and stroke. And we found that there was a reduction, a 15% reduction in this primary outcome, and this was statistically significant. When we look across the individual endpoints, we see that there's a consistent trend across these endpoints. And when we look at subgroups, there's no interaction. The effect seems to be present in all subgroups, in women, old, young, irrespective of type of myocardial infarction, and also irrespective of ejection fraction, although there was a trend towards having greater effect if the ejection fraction was below 50. Well, we now have 4 trials, actually 5 trials. One is a Japanese capital RCT, which was relatively small, but we have 4 trials looking at this now. Last year we had the REDUCE that was published, which only included patients with ejection fraction above 50. They found a hazard ratio of 0.97, but the confidence intervals was quite wide, and they concluded that there was no effect of beta blocker. We saw the REBOOT trial today, which is similar to ours, also included patients with ejection fraction above 40. They found no effect of beta blocker. In our trial, we did find an effect of beta blocker, but I think the devil is in the detail, because when you look at the ejection fraction below 50, both the REBOOT trial and our trial and also the Japanese trial found that there was an effect in this subgroup with ejection fraction below 50, whereas there was less effect in the ejection fraction above 50. So I think it all comes together that in this subgroup there is an effect across all of the trials. The REDUCE didn't include this subgroup. So there is an effect across all of these trials, and that fits nicely with what we already know about heart failure with mid-range ejection fraction, where evidence until now also seems to indicate that this group of patients have a benefit of beta blockers.